Hi, everyone. My name is Bruno Bohi, and today I'll be presenting a grand rounds case on Mycobacterium tuberculosis with a focus on a patient that was recently diagnosed with active tuberculosis alongside with a HIV co-infection. We'll be walking through the case's pathophysiology, case presentation, diagnostics, and treatment approach. So, with the case presentation, we begin with a 42-year-old male who presented with a 3 week history of progressively worsening cough. It started dry, but eventually became bloody. He also reported night sweats, low grade fevers, a 10-pound weight loss, fatigue, decreased appetite, and shortness of breath upon exertion. He recently migrated from South Africa 6 months ago and now lives in an overcrowded apartment. He works as a delivery driver, and he did have a history of heavy smoking. However, he did quit 10 years ago, and there was no other reported cases of alcohol use or drug use. No known tuberculosis or HIV history at presentation. So, in his physical exam, he does look tired and underweight. Lung exams revealed crackles in the right upper lobe, no extremity edema, and his abdomen was soft and non tender. Um, routine HIV testing came back positive. His CD4 count was 110 cells per microliter, and HIV RNA viral load was 128,000 copies per milliliter, which does confirm HIV. If we're looking here at his um, chest x-ray, which was taken in the posterior anterior view, it showed a cavitary consolidation in the right upper lobe, and this is very classic for finding and noticing tuberculosis. CT of the chest confirmed airway inflammation and showed small nodules consisted with tuberculosis. All three septum samples came back positive for an acid-fast bacilli, and a NAT, or a nucleic acid amplification test, confirmed the diagnosis of Mycobacterium tuberculosis. So, what exactly are we dealing with here? Mycobacterium tuberculosis is a slow-growing, rod-shaped bacillus with a waxy cell wall that's rich in mycolic acid. This waxy coating makes it resistant to the gram stain, so we need to use acid-fast staining techniques, specifically the Zeal-Nielsen acid-fast smear. Upon um, upon the smear being completed, all three septum samples from this patient were positive, and the NAT also confirmed this. So moving on to the epidemiology, globally, tuberculosis remains a top infectious killer. In 2022, there were 10.6 million new cases and 1.3 million deaths. Tuberculosis mainly spreads through airborne droplets, which means just simply talking, coughing, or sneezing can transmit it, which makes this a very infectious bacteria. While rates are highest in low income countries, tuberculosis is still very relevant in high income places like the United States, especially among immigrants, people with HIV, and those limited in healthcare access. This patient does check every risk box. He recently immigrated from South Africa. He is HIV positive, and he is living in an overcrowded house, which are all consistent with tuberculosis cases. So, looking here at the number of cases of TB and HIV co infection, we can see that in the early 2010s, it was a lot higher than it is today, we are in a downtrend. However, in the year of 2022, it looks like we are breaking that downtrend and coming up. Maybe because more HIV cases are being presented or whatnot, but this graph just show us that it's still a problem in the United States that needs to be taken care of. So moving on to the pathogenesis, the bacillus enters through inhaled droplets and reaches the alveoli and the lungs. It survives in alveolar macrophages, resisting destruction because of its thick lipid wall. In response to the bacteria, the body tries to trap the infection by building a granuloma, which is a wall of immune cells. But the bacteria don't die from this. They just end up going dormant. Um, they prefer oxygen-rich areas like the upper lobes of the lungs, which explains why we saw this cavity in the chest x-ray. In immunocompromised people, like this patient with low CD4 counts, the granuloma breaks down. That's when the infection gets out of the dormant state and reactivates, spreads, and becomes symptomatic and contagious. So looking here, we see a diagram showing the pathogenesis of Mycobacterium tuberculosis. Here we see the entry into the macrophages. Infection occurs when a person inhales droplets. Replication in macrophages is the earliest phase of primary tuberculosis, which is the first 3 weeks. A small number of bacilli may multiply and are released when the macrophages die. If alive, these bacilli may spread by way of lymphatic channels or through the bloodstream to more distant tissues and organs. For example, like regional lymph nodes, apex of the lung, kidneys, brain, etc. And then the development of cell-mediated immunity. This occurs approximately 3 weeks after exposure. T-cell mediated macrophages activation and killing of the bacteria does occur in this stage. And then in stage 5, the granulomas, inflammation, and tissue damage. In addition to stimulating macrophages to kill mycobacteria, the T-cell response orchestrates the formation of granulomas. So then we go ahead and move on to the treatment and prevention. Treatment starts immediately. The initial phase lasts 2 months and includes 4 drugs. Isoniazid, rifampin, pyrazinamide, and ethambutol. After that, we continue isoniazid and rifampin for another 4 months. The patient started ART, antiretroviral therapy, 2 weeks after beginning tuberculosis therapy due to his low CD4 count. He was also enrolled in DOT, which is the directly observed therapy, to ensure compliance and to prevent relapse. For prevention, the United States doesn't routinely use the BCG vaccine. Instead, we screen for and treat latent tuberculosis. Options do include the isoniazid for 6 to 9 months and rifampin for 4 months, or a 12-week combo of isoniazid and rifapentine. Public health plays a huge role in airborne isolation. Contact tracing and patient education are all very essential in treating and preventing tuberculosis. So to wrap up, this case highlights a classic presentation of tuberculosis in a high-risk patient. It underscores how closely tuberculosis and HIV intersect and the importance of rapid diagnosis and coordinated care. Even though we had an effective tuberculosis treatment for decades, it's still a global challenge, especially among vulnerable groups. Thank you for listening.